Hello, Brian Balke here from Hypnosis Rising. In this lecture series on therapeutic strategy in histotherapy, our theme is empowerment of clients to own their fulfillment. They come to us frustrated with their inability to change. We therefore began the series with the challenge of persuasion for agency. Our second lecture surveyed the landscape of personality, providing us with insights that help the client orient themselves for rebalancing of their mental faculties. What we must respect, however, is that the subconscious mind is conservative. After all, beneath the protective barrier of the critical mind are expectations and behaviors that have secured survival. If change is to be embraced, the subconscious must be convicted by a vision of growth that leads to compelling benefits. This conviction cannot be determined by the faculties of personality, which allow for infinite possibilities. Conviction follows from trust that the conscious mind is working effectively to recreate the social stability known in childhood. This journey towards social maturity is the theme of a story that is explored imaginatively before being realized and experienced. Success is achieved only with trust and collaboration across the barrier of the critical mind. In this lecture, we will consider narrative frameworks that the client may use to construct a story that leads from crisis toward maturity. We start with the Erikson stages of development. This crisis framework assumes that we will find supportive partners on our journey, but that disruptions and confusion leave us with attitudes that inhibit further growth. The remaining frameworks, adverse childhood experiences and body syndromes, normalize the choices made in surviving repressive environments. Under these circumstances, the conscious mind fixates on relief from emotional pain and social anxiety, often adapting or adopting addictive behaviors that mask these symptoms. In these cases, we seek to build a story that encourages the client as they define their social identity. In this lecture on narratives, we addressed a second strategy for learning socially responsible behaviors: stories. Our narrative frameworks allow us to reveal stories that may be implicit. An adolescent girl may gain insights from either Cinderella or the Frog Prince. Real life, however, is going to depart from the plot. That can be resolved by making the story explicit to our partners. But should they reject the plot, we need to change the story that we are living. Furthermore, life comes with transitions that demand new stories. We leave home and enter the world of commerce. We retire. Our narrative frameworks explain that progression, facilitating accommodation to the demands that come with increasing social maturity. In this lecture, we focus on narratives of crisis. Our next lecture will develop a narrative of social, mental, and spiritual integration. Having completed our survey of the elements necessary to organize growth toward responsiveness, our final lecture will turn to facilitation, how we structure dialogue and trance work to catalyze change. We have previously mentioned the Erikson stages of development, or SOD. Most of this lecture will be devoted to illuminating its depths. The SOD is a narrative of psychosocial crisis. We mature into ever larger social context. Each transition exposes limitations in existing behaviors, forcing us into a crisis of accommodation. The stages of development delineates these transitions and illuminates the attitudes instilled by success and failure. While we might hope that we would be allowed to struggle with the crisis until success is achieved, society actually forces us into larger social contexts, leaving us unprepared for the challenges ahead. Failure is compounded in the future. A single crisis may be the cause of multiple behavioral imbalances and rigidities. Few clients come to us conscious of the root cause of their self-limiting behaviors. Lacking this psychological key, they focus on unsatisfying outcomes, relationship frustrations, or professional failure. We apply the stages of development to diagnose the client's self-limiting attitudes. In subscribing to this narrative, clients gain insights that redeem their journey with meaning, hope, and fortitude, In addition, the insights inform our trance work, empowering the client with a sense of self-efficacy that avoids the need for a direct confrontation with the hidden crisis. As in our last lecture on the landscape of personality, we will not address recovery from the failed transitions in the SOD. This material is intended rather to expose the existence of failed transitions in a context that inspires the client with hope and determination. You will return to this material again and again during your practice, seeking the right seeds to plant in the mind of a client stuck in a therapeutic impasse. So let's review. The Erikson stages of development chart maturity through expanding social engagement. Each stage is driven by new partners and responsibilities. Our questions characterize each psychological challenge. Success or failure engenders characteristic attitudes towards self and the world. Note that our framing focuses on enduring psychological tendencies. In the original statement, the Eriksons sought to ensure that parents understood their role as developmental partners. Their goal was prophylaxis, to prevent failure. In our case, we seek to reveal the connection between expectations formed in earlier stages with current self-limiting behaviors. With these expectations brought to light, the client can take an objective look at their current social experience and pursue accommodations that lead to greater fulfillment. We introduced the stages in our lecture on personality, but did not elaborate on the psychological principles at play. As that understanding can empower clients seeking to fill gaps in their social skills, we'll elaborate more fully now. Prior to birth, the fetus has no basis for differentiation between self and mother. They are a single organism. Upon birth, the infant is still totally dependent upon their caregivers, but begins to evolve a sense of self as they become aware of the boundaries between their body and the world. The infant's first concern is survival. Guided by sensations of discomfort, they learn to signal with the goal of conjuring relief. The availability and competency of mother determines how much value the infant assigns to body sensations, modes of expression, and resting metabolic state. These expectations and behaviors are established in pre-verbal networks, making them difficult to access in therapy except through somatic imagery. In relationships, however, partners sense trust or mistrust, and these words are often accepted later in life to describe the resulting attitudes. Surviving infancy, around 2, the baby begins to seek physical independence from mother. They explore, encountering other authorities in the family setting, including siblings, but most importantly, father, who is in many ways a competent substitute for mother. As the baby learns to walk, feed, and use the bathroom, parental support and acceptance encourage autonomy. In learning to respond to father's unique gifts, a foundation for social flexibility is established. Conversely, in crisis, the child adopts shame. The attitude best expressed is, "Something is wrong with me." They will hesitate to enter novel social settings without validation from an accepted authority. Around 4, having learned to control their arms and legs, toddlers begin to imitate skills. Their elder siblings will include them in play. The availability of resources for self-expression and validation of their skill encourages initiative within a value system of right and wrong. A crisis at this stage saddles the child with guilt, the sense that what I do is wrong. At this time, in attempting to collaborate in adult activities, attitudes about authority become established. Successful children are socially assertive. They negotiate for a mutually satisfactory outcome. Conflicts with authority are more complex. Aggressive children use emotional and physical escalation to get their way. This can be found when they are rewarded for emulating an aggressive parent, but also when parents are unresponsive to the child's needs. Overactive parents, conversely, tend to create passive children who expect that others will solve their problems. More subtly, when a parent treats a child as a competitor, passive-aggressive patterns develop. Anticipating that effort, the child's anticipation that effort will lead to a withering critique from the father, they then show competence until the critique begins, at which point they will sabotage the project, leaving a mess for their critic to clean up. Patterns towards authority are often carried over into adulthood. In the developed world, at 6, most children are preoccupied with schooling. Teachers rank children against their peers, setting lifelong attitudes around industry and inferiority. Most critically, the structured setting instigates the emergence of the social identity in the conscious mind. In a diverse culture, children also become aware of social variety. They compare rituals and norms and absorb the attitudes of their elders regarding differences. A successful child leaves this stage with greater self-awareness and the ability, through the aid of the critical mind, to protect their social identity in the face of peer rejection. They also adapt comfortably to changes in social setting, adopting behavior appropriate to the situation. Note that success in this stage does not demand academic stardom. What is important is that effort brings enjoyment, either physical, mental, or emotional. When these are lacking, structured learning becomes a meaningless chore, a conclusion that is reinforced when the subconscious associates the mantra, "This makes no sense," when prioritizing what to capture from the day's events. This frustrates the formation of neural networks that assimilate the knowledge. Even when the learning environment is supportive, a child who is focused on excellence in other areas may need months or years for networks of structured learning to mature. When I was in graduate school, I developed a friendship with a machinist whose path to promotion was gated by algebra. He enrolled in adult education courses, and I spent 6 months patiently tutoring him. Suddenly, a light turned on, and he completed his studies independently. Adolescence brings physical competence that supports separation from the family, but the mind also changes radically. The brain sheds neurons, preserving what is most deeply integrated, while reorganizing behaviors around peer relationships. If accepted by a supportive community, we discover confidence in our identity. Conversely, social rejection leaves us shifting between poorly defined and ineffective roles. At this point, the innate sociability, the adventurer-protector polarity, developed with mother becomes fully expressed. Friendships follow the adage, birds of a feather flock together, and in that setting, tendencies are amplified through competition and imitation. Conversely, romantic associations initially accord with this adage, but conflict with expectations established in infancy. It is only in an early adulthood that we begin to pursue the stable complementary romantic partnerships, exemplified by the adage, opposites attract. Recognizing that the desire is to find someone like mom, father is the model for sociability. This need is divided in young women as management of hormonal cycles demands maternal wisdom. Without committed support for social development from father, however, young ladies will seek models outside the home. Concerning mother, both sexes are driven to attain independence, which often manifests as conflict. The depth of this programming is illustrated by studies that show mother's voice, once deeply comforting, triggers anxiety in adolescence. Success in this stage manifests as secure sociability, contrasted with neurotic sociability when the crisis is unresolved. Security in the peer environment rests upon a clear sense of competitive advantage, which is elaborated as an organized vision for independence. Having established a presence in society, the young adult seeks security and fulfillment through intimate partnership. While this seems to be a narrowing of social concerns, in fact, success involves social integration, often complicated by cultural differences between the partners. We are confronted continuously by evidence that our family system is not normative. Accommodation requires that we remain attentive to the physiological responses that we generate when negotiating conflict. In common terms, we must be emotionally responsible. We do not yell, gunny sack, threaten, or withdraw. True intimacy is attained when we learn to soften ourselves to receive the other. Hardened boundaries leave us in isolation. In softening, we allow our partner to occupy this psychological space, establishing the preconditions for nurturance. In attachment theory, secure partners cement intimacy by investing in their partners. They negotiate to win-win scenarios, building commitments that stretch forward through years. Crisis in this stage manifest in several ways. Financial priorities, ineffective communication, and conflicted sexuality may all drive relationships into crisis, making isolation seem attractive. Dr. Kappas, who first articulated complementarity as the E&P attraction, also revealed how crisis turns complementary toward antagonism, driving secure partners into neurosis. We will discuss this further in our lecture on the heuristic path. Fear also arises from family history. Some of us protect old wounds with avoidant distancing or suffocating anxiety. The secure partner finds themselves constrained by zero-sum thinking. Their gain is loss for the neurotic partner. However, beneath these emotional barriers to true intimacy, the subconscious is desperately trying to work out answers to problems imposed by earlier developmental partners. Both avoidant and anxious patterns reflect a lack of self-trust. When intimate partners grow distant, the social and organic realities deepen their conflict. The critical mind hardens. While the client may focus on grievances against past lovers, in fact, their distress is rooted in internal grievance. The conscious and subconscious minds raise the same complaint. I gave you what you wanted, and look what happened to us. As adults, we apply our lessons and skills in commerce, seeking wealth and allegiance. The principal challenge is mutuality. If our success does not extend to peers, they will redirect their attentions to others. Worse, if we exploit our peers, they will actively resist our influence. In either case, our creative potential plateaus and we enter an era of stagnation. To those attentive to a balanced exchange in our partnerships, our reputation buys access to larger creative opportunity. Society embraces us as generators of value. At the end of our careers, our vision far exceeds our grasp. We cannot do all the work ourselves, and so must inspire youth to subscribe to our influence. This exposes our vision to competing priorities that will exploit any inconsistency in our goals. Our personal integrity is therefore essential to realization of our life's work. Without it, we are threatened by despair, the attitude that in the end, no evidence of our existence will remain. With the exception of adolescence, the age of each crisis is only indicative. In the new millennium, our youth are expected to continue schooling until well into their 20s, each graduation followed by a sundering of social ties that undermines identity. More subtly, elders struggling with despair hang on to power, building cohorts of sycophants that starve creators of resource. We thus find ourselves stagnating under the rule of octogenarians. As age is variable, we use attitudes to diagnose and guide our clients. One may complain of isolation, but we probe further to determine whether attitudes from earlier failed stages block their surrender to intimacy. We then begin peeling the onion, validating the opposing attitude, the attitude of success, and identifying experiences in which expression of the success attitude builds towards success. In that process, the therapeutic relationship itself is critical. We will be criticized for disappointments, but by our responses demonstrate that curiosity and goodwill empower learning and growth. The stages of development assume supportive social partners, even if those partners are motivated only by the expectation that they will benefit from our competence. In contrast, repression occurs when dominant partners actively suppress our growth. The psychology of the oppressor is conflicted. In effect, the oppressor manifests patterns that reflect the expectations instilled by their own history. This may be physical, emotional, sexual, or spiritual abuse. Universally, dependent children seek relief through compensation, finally developing skills that facilitate escape. For this reason, later in life, abusers become more sophisticated in their psychological methods of control. Clinical experts in these areas study the manipulative reasoning particular to each form of abuse. Those insights allow them to work systematically to liberate patients from self-limiting thoughts. In our narratives of repression, we do not descend to that level of detail. Rather, we seek to reveal the damage wrought in body, mind, and spirit so that the client can organize resources for healing. The stages of development assume an organized search for self-expression. But what happens if that process is continuously disrupted in childhood? Will the conscious mind evolve a coherent self-concept? This is the concern that drives us to assess adverse childhood experiences, or ACEs. ACEs involve violation of partner roles in any stage of development. Inconsistency, separation, and betrayal characterize these violations. The incidents may be papered over in the adult personality. We can bring them to light in surveying of significant events in childhood, and the age of occurrence will often guide our diagnosis of self-limiting attitudes. Under abuse, we can explore emotional, physical, and spiritual abuse to trace the consequences in the adult personality. Discussion of sexual abuse, however, must be reserved to a clinical setting. Abandonment, incarceration, or death that removes a partner almost always aborts a transition in the stages of development, and often leads to regression to the prior stage. Loss of a partner can be alleviated when a substitute is available, such as a nanny or step-parent. Children are flexible to a degree. We should not imagine, however, that a child is ever too young to remember. Rather, the attitudes of failure are encoded in pre-verbal networks that are difficult to access in talk therapy. Codependency is a role reversal. The child assumes responsibility for regulating the emotions of their physical caregiver. Awareness that should be turned inwards is externalized, often manifested as hypersensitivity in later relationships. A mild form of this arises when the boundaries between school and home are blurred, delaying the development of the conscious mind. Most often, however, mistrust of a parent presages substance abuse or psychological instability. Social instability is most troubling in the K to 12 years. The children of military officers experience this deeply as they relocate every couple of years under rotation. Instability can be global, however. Administrators in higher education are recognizing COVID as a generational disruption, and 9/11 may have had a similar effect. Finally, a serious illness or injury not only disrupts socialization, but forces the body to allocate resources to healing that would have been invested in the growth of the personality. Clearly, any one of these wounds can instill an attitude of failure in the affected stage. What psychologists observe, however, is that repetition or combination of wounds can undermine the self-concept. In the sense that I is represented in our theory of mind, we grow up believing that I doesn't matter. A healthy self-concept is predicated upon physical and emotional security. Lacking that, the mind focuses on finding patterns amidst chaos. Starved of social nurturance, the relational part of the mind fixates on sources of emotional relief, including addictive substances and behaviors. Criminality is an assertion of identity against society that unfortunately reinforces isolation. Emotional volatility breaks through inner barriers, creating a brief flicker of life in crushing darkness. Most troubling when an infant concludes that their primary caregiver can be dangerous. The desire for relief can be tied to self-annihilation. The effects, however, are not limited to the realm of psychology. Chronic anxiety induces inflammation that is a precursor for all chronic diseases, including diabetes, heart disease, and dementia. Among these behaviors, substance abuse and suicidal ideation require the involvement of a licensed specialist. When emotional volatility is expressed violently, trance therapy is not only ill-advised but potentially dangerous. When clinical patterns such as these are evident, As Christotherapists, our focus is to celebrate inner fortitude and strengthen pro-social attitudes and behaviors. While we focus here on childhood, we should be aware that chronic trauma erodes the social identity in adults. This is evident in the stubbornness of homelessness. Provision of basic needs is only the first step in a return to social participation. Collaborative behaviors and intellectual skills must be reactivated. In therapy with such clients, our first goal is to persuade them of their efficacy. Overwhelmed by crisis, yet they have made it thus far. They can rely upon identifiable skills and attitudes. Enumerating those aptitudes seeds self-awareness, the foundation upon which we persuade them to erect their social identity. The antidote to all the consequences listed here is a brave assertion that, in fact, our I matters. Now we turn to body syndromes, once called hysterical conversion, and now talked about as, hold on, psychoneuroendoimmunological disorders. The obscure terminology hides a simple truth. Unresolved inner conflict is projected into the body. Let's understand this. Upon recognizing a pattern of experience, the neurons in the brain that signal the event will interfere with other networks until they succeed in triggering a behavior. In our prior example, the child stacking blocks turns toward the antagonist who knocks them down. When authorities repress a social response, the only means of grounding the signal is by channeling it into the body. The child that lacks words to express his frustration will turn to feet and fists. When those are suppressed, the muscles lock, creating persistent tension that limits blood flow. Allopathic medicine, with its medication and surgeries, does not honor its limits in managing such discomfort. Steve Wozniak in The Great Pain Deception explains how hypertension eventually builds towards disabling pain. Gabor Mate in When the Body Says No describes the personality profiles that develop chronic diseases, such as ALS or IBS. In milder cases, disease may not manifest, but the blood-starved tissues will still be most sensitive to allergens or toxins. We might expect that children exposed to ACEs will be prone as adults to such discomfort. Depending upon what part of the body is most suited to an effective reaction, various types of repression will manifest in specific parts of the body. Some systems of body-mind syndromes trace these interactions down to organs and specific muscles. This is an area of specialization. Here we provide a basic model useful in building resolve in clients to address their self-limiting choices. This is essential when they have ceded authority to medical clinicians who can treat only symptoms. When discomfort is localized in the head, we should seek to identify frustrated plans and frustrating relationships. In the shoulders and chest, the client is often carrying practical emotional responsibility for another's choices. When the arms cannot grasp a goal or defend against a persistent threat, discomfort will manifest in fingers or joints. The hips are where we find pleasure, or at least what is toxic to us. Finally, weakness or discomfort in the legs signals feelings of being trapped or lacking power to change. In the course of studying our applications, you will learn specific techniques for displacing body syndromes while empowering effective alternatives. In this lecture, we offer narratives of crisis that allow a client to relate social difficulties to attitudes that we can shift through therapy. In that Christotherapy is self-improvement, we should make the paradox explicit. Why is it that social difficulties are the driver of self-improvement? Simply because in the lack of social support, our imagination generates uncomfortable predictions rooted in the painful outcomes that arose in infancy when our parents were inattentive. The stimulated signals are only dampened by the release of endorphins, the brain's natural painkillers, when we receive comfort from another person. Thus, our ability to establish and maintain social connections is an essential part of our personality. The stages of development starts with this truth and charts the natural expansion of social influence. In the later stages, we naturally associate with executives and politicians. Clients working to overcome the effects of a childhood crisis may be intimidated by such ambitions. This is why we focus on attitudes rather than outcomes. The stages of development also fails to recognize the regressive impact of repression later in life. One way of interpreting depression is as an attempt to reach deeper networks of expectation when confronted with inescapable social hostility. As children cannot escape hostility, they bear such scars of repression most clearly, but vulnerable adults can also receive deep psychological wounds. These are surveyed in our narrative of adverse childhood experiences. Repression also leaves signs in the body, generated by internal tension that is itself a form of expectation. The theory of body syndromes reveals the logic of that narrative, guiding us into therapies that release tension, liberating the client to more fulfilling choices. These narratives focus most directly on the cost of social crisis. We use them to diagnose the cost of self-limiting behaviors. In our next lecture, we will offer a view of personal growth that guides integration of the personality, the heuristic path.